So pattern recognition in neuroradiology. Actually, this is the outline of my presentation. We will do pattern analysis based on topography, on vascular territories, on signal intensity changes on MR, and on the pattern analysis of contrast enhancement. Pattern recognition, what is it? Well, actually, it's the ability to match the appearance of a new image to a previously imprinted image pattern in our brains. But in a more easy way, it's more or less like this game. Who is it? You have to find the suspect person in this game. Is it a man? Is she a woman? What's the age? How the eyes look like? Does he wear glasses? What about his lips? The color of the hair? Does he have a mustache? Well, if you find these questions and you have this information, you can put all this information together and then you can find who the suspect person is, as you can see from this image. Well, the same approach is used in pattern recognition in neuroradiology. Where is the lesion? Is it in the suprarachnoid space? Is it supra or infratentorial? More precisely, is it in the basal ganglia? How does it look like on T1, on T2? Does it show restricted diffusion? Are there calcifications on CT or on susceptibility-weighted imaging? What about the contrast enhancement? And how do the lesions look like? Is it ovoid? Is it round? So let's start with just an easy case. Clinical information, 29-year-old woman, and she's in the hospital. I don't know why they didn't tell me. And CT scan is performed because of acute onset of narcolepsy. So here is the CT, and I show you all the images. Take a close look. Where are the lesions? Intraaxial or extraaxial? Infratentorial or supratentorial? And where more precisely? That's the questions you should ask. Well, here you clearly can see there's not one lesion, but there are two lesions, and both are in the posterior fossa, and it looks like they are within the parenchyma. They look like intraaxial lesions. Well, that's what it is. It's intraaxial, it's infratentorial. Two lesions, one is arising within the left cerebellar hemisphere, the other one is in the posterior aspect of the left cerebellar hemisphere. So, how does the lesion look like? Take a good look at the density. Well, it looks like it has a density of fluid. Are there just one lesion or more lesions? I think we already decided there are two lesions. This is a CT after contrast. Do the lesions enhance? Well, I don't see much enhancement on these images. We should ask ourselves, what's the age of the patient? Because this can help us in the differential diagnosis. Well, actually, it's a 29-year-old woman, so it's an adult. So on MR, you see here the actual T2-weighted image, which confirms it's a kystic lesion. And here, after gadolinium injection, we see there is some small enhancement in the wall of this cystic structure. It is what is called a mural nodule. Well, with all this information together, we can come to a good differential diagnosis. So, if we fit all this information together in an adult, the first differential diagnosis would be hemangioblastoma. It's a cystic tumor with a mural nodule. If this would have been a child, the first differential diagnosis would have been a pilocytic astrocytoma. As you can see in this case, this is another patient, this is a young child, where you see a cystic lesion with a nodular component in the wall of the cyst. It shows some enhancement after gadolinium injection. This is an example of a pilocytic astrocytoma. Sorry for that. So, let's take another look at the clinical information. If we look into the electronic patient file, we know that she was hospitalized because she had a resection of a renal cell carcinoma. So if we add this information together with the family history, where you see that a lot of her family members, they died of cancers and they had brain tumors. If we have all this information together, this is a CT scan of the patient that was operated on. You see a lot of cysts in both kidneys, and here there is a mass lesion which looks quite heterogeneous enhancing. This is a renal cell carcinoma, and with all this information together, this can be only one thing. These are two hemangioblastomas arising within the cerebellar hemispheres. Together with the renal cell carcinoma, this fits perfect with the diagnosis of von Hippel-Lindau syndrome. Okay, that's the way it works. So start now pattern analysis by topography. This is a young woman, and she presented with an acute right-sided hemiparesis. This is a T1, T2, and FLAIR image that shows you multiple white matter lesions in both cerebral hemispheres. After gadolinium injection, you see that some of the lesions are enhancing, but not all of them. On the sagittal FLAIR, you see the lesions have more or less an ovoid shape. Some of them are close to the corpus callosum in the periventricular white matter. Other lesions are in the juxtacortical white matter. So, if we see lesions with this shape and morphology in the periventricular area, the juxtacortical area with enhancement of the lesion, if we find lesions in the infratentorial compartment, if we find lesions in the spinal cord, this all fits nicely together with a patient with multiple sclerosis. So once again, you see here all these lesions, and this shows dissemination in space. This is the same patient, other slices, where you see that some of the lesions are enhancing. Actually, this is the lesion that was explaining the clinical symptomatology of the patient. So we see enhancing lesions and non-enhancing lesions. This is a follow-up study where you see that some of the lesions have disappeared and that there is a new lesion over there. So if we see this phenomena, this is dissemination in time, and I'm quite sure that you already made the diagnosis now of multiple sclerosis. If we see white matter lesions, you have to look for this typical distribution pattern to make the differential diagnosis with vascular lesions. I listed them up in this scheme that you can see, where you see the most important information again. As I told you, corpus callosum is a common location of MS lesions. Also, the juxtacortical white matter is a common place to find these lesions. You will not find it in vascular lesions. Just the same information on this image, where you see that a lot of these lesions will have a typical perivascular or perivenular pattern. This is really very typical for MS lesions, and you will not see that in patients with vascular lesions. This is a nice image that I took from this paper from the group from Kilsdonk and collaborators. This is a FLAIR image that was realized at 7 Tesla. And you see, it's not a flare, it's actually a flare star. It means it has combined information what is T2 weighted, it is water suppressed, but you also have information on susceptibility. So you see nicely the veins, and just centered around this lesion, these perivenular lesions, these are typical for MS. This is another patient where you see also white matter lesions, but this is a patient with a vascular disease, and there you see that the lesions are not in a perivenular distribution as it is with MS patients. The nice thing is that we not only can see these lesions at 7 Tesla, but recently also at 3T, you can have this combined FLAIR and T2 star weighted image, nicely showing you the phenocentric position of the lesions in patients with MS. Here's a patient similar to the one that I showed you before. We see a vein over here in the brainstem, and we see one of the MS lesions, which is typically surrounding this vein in the brainstem. Let's take a look at another patient, a 2-year-old boy. He had recurrent respiratory infections, delayed language development, and the mother is pregnant again. And because of this, an MR examination was performed. This is a T2 weighted image where you nicely also see the perivascular spaces that are enlarged, and we find some lesions that are centered in the corpus callosum. They have the signal intensity of cerebrospinal fluid on all the imaging sequences. They actually look like just ordinary perivascular Virchow-Robin spaces, but when you see them in the corpus callosum, Notice over here, if you see this typical distribution, you should consider the potential diagnosis of a mucopolysaccharidosis, and actually this was the case in the patient who had, it was confirmed later on genetically with Hunter disease, which is mucopolysaccharidosis type 2. Okay, let's take a look at pattern analysis by vascular distribution. Here we see a patient who has swelling of the cortical gray matter. You see there is high signal intensity on diffusion weighted imaging. If this is a patient presenting with acute symptomatology, probably you would go for a diagnosis of an ischemic stroke. These are coronal T2 weighted images, nicely showing you the same thing. There is gyri-form swelling, the cortical gray matter is swollen, has an abnormal signal intensity. This is something that you typically will encounter in a patient with a stroke. To be sure that this is ischemia, you will do diffusion weighted imaging. Always remember, it should be bright on diffusion weighted imaging, and it should be black on the ADC maps. If it is not black on an ADC map, it can be that you are looking at what is called a T2 shine-through phenomena. This is the MR angiography that was performed, and you notice that part of the M3A at the left side is missing, and this is because a small thrombus was staying there, and actually this thrombus was the cause of the ischemia. Of course, you have to know your different vascular distribution territories. If you don't know them by heart, it's good to have a book on your bookshelf, or if you don't have books available, there's a website that I really can suggest you to go to. It is the Radiology Assistant website, which was made by young Dutch radiologists, and I really use it very frequently myself. This is another patient, CT scan performed 5th of October, some years ago. Nothing special to remark on this image. Some days later, 3 days later, you see that in the same area there's a hypodense region, and this region is the distribution of the anterior cerebral artery. And if you will do MR in the same patient, this is FLAIR, this is gradient echo, T2 star weighted imaging. You see there is no hemorrhagic transformation of the infarction. Is it an acute infarction? Yes, it is, we know from the clinical information. But if you do diffusion weighted imaging, you will see it's bright on diffusion, it's black on ADC, it's not T2 shine through. This is really restricted diffusion in a patient with acute ischemia. Let's take a look at the next patient. It's a very typically image, and you will not forget it from now on anymore. We see a patient, we see high signal intensity on diffusion in the posterior limb of the internal capsule at the right-hand side. It is bright on diffusion, it is black on ADC, so this can be acute ischemia. Which artery is responsible for the posterior limb of the internal capsule? Well, it's the anterior choroidal artery. So if you see these signal abnormalities, this fits nicely together with an anterior choroidal artery syndrome or infarction. This is a patient who had problems many years ago. You see an area of abnormal signal intensity on T2. It looks like it has the same signal intensity as the CSF in the ventricles. We see it's very dark on the FLAIR. We see areas surrounding this with high signal on the FLAIR images, and it looks rather hypo-intense on the T1 weighted image. Well, actually, this is an example of a patient who had multicystic encephalomalacia. There is secondary enlargement of the right lateral ventricle. The tissue loss has more or less the same signal intensity as the CSF. There's an area of gliosis in the periphery of the lesion. We have ipsilateral ventricular dilatation. This is an old infarction. If we take a look at the posterior fossa, you will see that there's a normal flow void in the left internal carotid artery. When we take a look at the right side, we say there's high signal intensity where we expect to find the normal right internal carotid artery. There is absence of a flow void, so this means there is absent flow, there is thrombosis in the right internal carotid artery, and this is confirmed on this coronal MR angiography image. We see the absence of the right internal carotid artery, which should have looked like this one. So take a look again at the brainstem, we see there is some atrophy at the right-hand side. We see high signal intensity in the right corticospinal tract. You see the atrophy. Well, this is typically what is called Wallerian degeneration. So actually what you see is an abnormal signal in the corticospinal tract which is absent in this patient, and this is due to Wallerian degeneration secondary to an alt infarction in the right MCA artery distribution. Okay, this is another patient. We see on the sagittal flare an area of high signal intensity. This is confirmed on this image. This is T2, showing you the same thing. You do diffusion weighted imaging to know whether this lesion is an acute lesion or a chronic lesion. Well, it is bright on diffusion, it is black on ADC, this is restricted diffusion, this is an acute infarction, this is called a lateral medullary syndrome or Wallenberg syndrome. Let's take a look now at pattern analysis by signal intensity. You know that most lesions are bright on T2 and they are dark or iso-intense on T1 weighted images. Well, this is rather aspecific. They reflect an increased water content in most vascular, infectious and tumoral lesions. This is due to the presence of intracellular water with a low nucleus to cytoplasm ratio, or due to intercellular water like you have in vasogenic edema. Free water, like you have in arachnoid cysts, also will show bright on T2 and dark on T1. A technique to make the differential between the possibilities is using the flare, because this will differentiate pure fluid from abnormal tissue. Just an example, lesion over here, you see high signal intensity on T2, it has low signal intensity on T1, actually it has the same signal intensity as the cerebrospinal fluid, so this is an arachnoid cyst. Let's take a look at another example, where you find a patient who has a lesion which is rather dark or iso-intense on T1, it is bright on T2, it is bright on flare, maybe some little enhancement after gadolinium injection. Let's take a look at the diffusion weighted imaging. Does it show the signal intensity of water? No. It shows high signal intensity on diffusion. There is maybe some hemorrhage or some calcification on gradient echo T2 star. This is not an arachnoid cyst. This is an example of an epidermoid cyst. So diffusion weighted imaging can help us to make the differential diagnosis between arachnoid cysts and epidermoid cysts. A typical location for epidermoid cysts is in the cerebellopontine angle. We see here a lesion with low signal intensity in the right pontocerebellar cistern. You see the signal intensity is not the signal intensity of cerebrospinal fluid. If you use diffusion weighted imaging, you see it's bright on diffusion, it is dark on ADC maps. This is a typical example of an epidermoid cyst in the right pontocerebellar cistern. Let's take a look at the next patient. Patient has some abnormalities in the right temporal lobe. We see a lesion over here. It has heterogeneous signal abnormalities. In the periphery, we see a hypointense ring, which is possible due to the hemosiderin deposition. Centrally, we see high signal intensity. For those of you who know what it is a typical example of a cavernous malformation. But what about the signal abnormalities we see on T2 and on flare? On flare, we see there's more or less the gray matter, which has an abnormal signal intensity. The gyri are a little swollen, and here on T2 we see there is more what we would call white matter edema. This looks like there is white matter edema also. There's not only abnormality in the cortical gray matter, but there's also signal abnormality in the white matter. On T1 we see a slight dot of high signal intensity, which you typically find in cavernous malformations. So if we have edema, you know you have different kinds of cerebral edema. It can be cytotoxic or it can be vasogenic. Well, there is one technique that you can use to make the differential diagnosis between the two of them, and this is diffusion weighted imaging. This is the diffusion weighted image, two of them, with their comparable ADC maps. If we look at the diffusion weighted imaging, you see there's high signal intensity in the cortical gray matter. Well, it is dark on ADC, so it's restricted diffusion in the cortical gray matter. So this is cytotoxic edema. If we look for the other compound, the other component in the white matter, we see it has no restricted diffusion in the white matter. So what we are looking here is the vasogenic edema in the white matter, which doesn't show restricted diffusion, but shows high signal intensity on the ADC maps. Notice also that in this patient, there's not only restricted diffusion due to edema in the cortical gray matter, but there's also in the ipsilateral thalamus, there's a focus of high signal intensity. And actually this patient who suffered from a headache has both cytotoxic edema and vasogenic edema as a result of a non-convulsive status epilepticus. The cavernous malformation was giving rise to seizures, and because of these seizures you had these signal abnormalities with cytotoxic edema in the cortical gray matter and vasogenic edema in the white matter. So let's now take a look at lesions who have a high signal intensity on T1 weighted images. They are listed over here in the group, and I think the most important ones are hemorrhage in the subacute to chronic hemorrhage, melanin, as you can have in patients that have metastatic disease as a result of a melanoma. You can have ions that are associated with necrosis or calcification, or you can have lesions who have increased protein concentrations, fat, or you may also have it in flow-related enhancement in blood vessels. So just some examples. This is a case of a patient who had an early subacute hemorrhage. You see on the T1 weighted image there's a high signal intensity on T1. If you see an hemorrhage who has high signal intensity on T1, it means this is the early subacute state of the hemorrhage. The very early hemorrhage will show isointensity to the brain. This is a patient with many lesions in the both cerebral hemispheres. They are in the periphery, in the more subcortical areas. They show low signal intensity on T2. Well, this is a native T1 weighted image. This is not after gadolinium injection. If you see lesions that are spontaneously hyperintense on T1, and this patient, if he has previous medical history of a tumor, these are metastatic lesions from a melanoma. And this is how they look on pathology. This is the melanin, which shows also on pathology. This looks dark. Another patient, you see it has the same density. It's just in contact with the mesencephalon, with the quadrigeminal plate. You see it has the same density as the fat tissue in this patient. If you do MR, this is sagittal T1, you see it is high signal intensity on T1, the same signal intensity as the subcutaneous fat, so it's an easy diagnosis. It's a patient with the lipoma. Just another case in the more typical location, it's a pericallosal lipoma that you very frequently will see in patients with callosal dysgenesis. Let's take a look now on lesions that have a low signal intensity on T2. You can see from this list the different possibilities to mention in your differential diagnosis. Young patient who had a brain trauma. This is a CT scan. If you take a good look, you might notice there's this small area which is high density on the enhanced CT scan. So maybe this is a small spot of blood after the trauma. You all know that MR is much more sensitive to pick up these hemorrhagic lesions in patients who had trauma. And if you use MR, the best techniques to use are gradient echo T2 star weighted imaging, or if you have it available on your machine, susceptibility weighted imaging. You nicely will confirm the presence of this dot that you already saw on the CT scan, but you will see more lesions are seen on the gradient echo T2 star weighted imaging, and you are typically in the frontal areas, and you will typically find them in the subcortical white matter. If you see these lesions, also in the corpus callosum, which is a typical place for these microhemorrhages in trauma patients. A similar like lesion, this time in the spinal cord. we see a heterogeneous lesion, which is most hypo-intense on the T2 weighted image. You see it is bright on T1 weighted image. You see there is another small lesion over there. This is confirmed on the gradient echo T2 star weighted imaging. So these are hemorrhagic lesions. There's some enhancement over here in the surrounding white matter of the spinal cord. And actually this is a patient who had a bleeding in a cavernous malformation with a second cavernous malformation over here. So we also performed MR imaging of the brain. This is, again, the gradient echo T2 star weighted image, where we see numerous hypo-intensities, typically for a patient with cavernous malformations, and this in a familial form. There's another case where you see a patient with a mass lesion. Always ask yourself the same questions: supratentorial or infratentorial? Well, it's supratentorial. Is it intraaxial or extraaxial? Well, actually, it is outside of the brain. It's an extraaxial lesion. It's in the frontoparietal area of the right side of the brain. You see some pattern of hypo-intensity over here. You see there's restricted diffusion with high signal intensity on diffusion. Well, also the enhancement pattern, we see there is a dural tail. If we have all this information together, this can be only one thing. This is a patient with a meningioma. Another patient, this time with a lesion, which in the infratentorial compartment, it's an extraaxial lesion. We see a CSF cleft separating the lesion from the normal brain tissue. So if you have the differential diagnosis in the cerebellopontine angle cistern, this can be only two things: whether it is a meningioma or it's a vestibular schwannoma. One of the old tips and tricks to know what kind of lesion it is, if you would measure the angle between the dura and the tumor, we have an obtuse angle in this patient. This is what you typically will find in patients with meningioma. Similar like lesion in another patient, this time on the left-hand side. It's in the posterior fossa, it's in the cerebellopontine cistern. You see a CSF cleft. This is an extraaxial lesion. Is this a meningioma or is this a vestibular schwannoma? You see that the contrast enhancement is not homogeneous like it was in the previous patient. You see the lesion is really extending into the internal auditory canal. Well, this is a case of a patient with a vestibular schwannoma. And if you would measure the angle, you will see you will have an acute angle. And this has been described in the literature that it is typically for vestibular schwannomas. So all these little tricks can help you to make a good differential diagnosis. Before I end, I would like to discuss with you shortly pattern analysis of contrast enhancement. This is a patient who presented with some symptoms. You see on the unenhanced CT a hypodense mass lesion. The colleagues of the neurology, they really were sure that this patient had a meningioma. Contrast was administered, so we did a CT scan after contrast injection, and we see there is some enhancement in the periphery of this lesion. We performed MR to see if we could make a better differential diagnosis of a mass lesion. We see now an area with huge signal abnormalities on the coronal T2 weighted imaging. The lesion has a very strange appearance, areas of higher signal intensity, areas which have an intermediate signal intensity. And if we give gadolinium, we see there are areas of enhancement and there are layers of non-enhancement, and then again a layer showing contrast enhancement. Always take a look at the four corners of your images, because you might have not seen there's another lesion over here. So of course it was not difficult to see there's a lesion over here, but there's another lesion over there. So fitting all the information together, we made the correct diagnosis of a patient with Ballot's concentric sclerosis, and this pattern of contrast enhancement is known as the onion bulb sign. There's another patient. We see a lot of lesions in the white matter of both cerebral hemisphere. Notice it's not only a lesion in the periventricular white matter. Here you see a lesion in the juxtacortical white matter. I think this might help you to make a correct differential diagnosis. We have multiple lesions. It's a lesion in the corpus callosum. If we inject the gadolinium, we see that the lesions show what is known as open ring enhancement, and if you see multiple lesions in the typical locations with the typical morphology and this kind of enhancement, this is a patient with multiple sclerosis. I really would like to suggest that you read this overview paper that was published in Radiographics from the group of James Miniotopoulos, because it will deal with all the different patterns of contrast enhancement. Is the lesion, has it a smooth circular enhancement? Does it have an irregular form of enhancement? Does it show a peripheral mural nodule like we saw before in the patient with hemangioblastoma and pilocytic astrocytomas? If you take a close look at these patterns of enhancement and you remember them, you will make correct diagnoses in this patient who had abscesses in the brain, a patient with a lung cancer who had a metastatic lesion into the brain, posterior fossa lesion. We see some enhancement in the wall of the cyst. There is a mural nodule. This must be a fluid secreting tumors. This can be in a young child a pilocytic astrocytoma. When it's an adult, it can be a hemangioblastoma. So, I hope that I showed you that in the clinical context that you have, and you look carefully at all the images, and you look at all the information that is within the image, you would use a systematic approach to make your differential diagnosis. Look for location, location, location. Don't miss any lesions. What is the density on CT? What are the signal intensities on T1 and on T2? What about the contrast enhancement? Is it homogeneous? Is it patchy? What about some other specific characteristics? Does it contain fat lesion? Is it calcified? Does it show restricted diffusion? What about perfusion if you would do perfusion-weighted imaging? And what about the MR spectroscopy findings? Well, with all this information together, you should be able to make a nice differential diagnosis. And in your impression, I would suggest you that you take some position. You will not say it's this one of these 50 kind of lesions that it can be, but you say, I would go for the diagnosis of this kind of tumor. And with that, thank you for your attention.